Hi, I'm Ross Camidge. I am the Director of Thoracic Oncology at the University of Colorado. Brain metastases has long been recognized as a major issue in advanced ALK-positive lung cancer. To some extent, there's some inherent neurotropism in this subtype of lung cancer. Maybe something like 40 to 50% of people will develop deposits in their brain during their lifetime. I think this got exaggerated initially because the first ALK inhibitor, crizotinib, was actually very poor at penetrating into the brain. And so the brain was often the first site of progression, and often it was the only site of progression. And I think that's what really woke the field up to thinking that we needed to deal with the brain in a more mature, in a more robust manner to generate real data about its efficacy. Now, the great thing is that many of the next generation ALK inhibitors, notably alectinib, brigatinib, and lorlatinib, have got fantastic activity in the brain. And not only will they cause shrinkage, but they will maintain that shrinkage in the brain. Now, it used to be if the patient walks through the door and they have brain metastases, the first thing you would do is, if it was an isolated area, maybe you'd send them to the neurosurgeons, or maybe you'd send them to the radiation oncologists. If there were multiple deposits, maybe you'd send them for whole brain radiotherapy. That is all yesterday's paradigm. These drugs are now so good that you should really think about putting somebody on the tyrosine kinase inhibitor and keeping all of those other local treatment modalities on standby. Now, I can tell you that it wasn't that long ago before the radiation oncologist was saying, you're crazy, you can't do this, or the patient is symptomatic, I've got to treat them with radiotherapy. You can get somebody to respond symptomatically in the brain before they can get their first appointment with the radiation oncologist. The surgeons were particularly hard to convince, because often somebody considering neurosurgery is an inpatient. They've come through the emergency room with a seizure, and the surgeons really want to get their hands on them. But no, if you know they're ALK positive, and of course that's the issue, can you figure out that they're ALK positive in a quick enough time? But maybe you find that in a blood test, maybe you knew that from before, maybe you get a rapid turnaround time. But again, your tyrosine kinase inhibitor will work within hours, if not days, of starting on one of these drugs. Now, other things you need to think about. So let's say you're on a next generation ALK inhibitor and you progress in the brain. You might have initially responded and then you progress. What's going on? Well, the first thing is, don't overthink it. If it's just a single spot, maybe there's some acquired resistance going on, but probably what you need to do is zap it with radiotherapy, focus stereotactic radiosurgery, and stay on the same drug. We know that for people progressing on one next generation inhibitor, even though they're all showing activity, that the activity is not equivalent. We know that patients could respond in the brain on alectinib after progressing in the brain on suritinib. We know that patients can respond in the brain with lorlatinib after progressing in the brain on alectinib or brigatinib. In fact, lorlatinib is so good in the brain, when they first showed the data, you could pull apart the data in terms of the intracranial response rate and the extracranial response rate. And the intracranial response rate was always higher. And people were surprised by this. You'd look in people who'd had multiple lines of therapy, and you'd get something like a 60% response rate in the brain and a 25% response rate outside of the brain. And of course, when they present an overall response rate, it's somehow combining all those things together and you don't know what's in it. What's going on there? Well, don't forget, if less drug is getting into your brain through these other lines of therapy, it's behaving as if it's an earlier line of therapy. It's more treatment naive, and that's why the response rate is higher. So I think if you then progress further in the brain and you can't do local therapy and you can't do neurosurgery, what are you going to do? Probably the future is going to be about figuring out why stuff is progressing in the brain other than just pharmacokinetic issues. People are now developing the technology that we look for circulating free DNA in the blood to use the same thing in the cerebrospinal fluid. Are we in the future going to be able to draw a pie chart of different mechanisms of acquired resistance in the brain, and really think about acquired resistance? So you initially respond in the brain and then you progress, as opposed to you didn't have anything in the brain and then something appears. That may not be acquired resistance. That's much more likely to be a drug penetration issue. But if it's true acquired resistance, gets better, gets worse, I think we need to start to figure out how to molecularly profile this. I think we're going to be looking in the cerebrospinal fluid, and maybe it's going to be a completely different pie chart. Maybe the microenvironment in the brain is going to lead to completely different variants, and it's going to be a very exciting time in the future.